Yeah, and I would like to thank the Faculty of Medicine, Batiklo, for giving me this opportunity, and Lalisha for organizing this, and of course my batchmate Dr. Vaidehi, who facilitated this. And and also there is a special group of people I would like to thank. Actually, uh, it is uh, it is from a group who came to me for onco-surgery appointment, 12th batch. I think the group prior to Lalisha's group, because the thought of doing this lecture came after talking with them. Um, so during that appointment, I asked one day, so do you know what this month is, I mean, significant for? What do you do in this month in relation to cancer, I asked. So none of them could answer, and none of them was aware that this was this month of October, last month actually, is actually dedicated for breast cancer awareness. So thank you for motivating me, I mean, reminding me that so an important group I mean, you all are future doctors, are actually were not aware. That is not your fault, but it's actually you all were not made aware, isn't it? Right. Right. Okay. Breast cancer. Knowing it, uh, knowing it exists is not enough. So I think that suits this. So I'm as Larisha told, I'm a consultant breast oncological surgeon, breast and oncological surgeon. Right. Okay. Hold on a second. I need to move this away from right. Okay. Cool. Right. Okay. Breast cancer. Knowing it exists is not enough, isn't it? I mean, most of us know that breast cancer exists, right? So is it enough? I feel it is not, right? So in this slide, you can see, this pink ribbon shown. Does anyone know the significance of this pink ribbon? So wherever you see posters about breast cancer awareness, you will see this pink ribbon and pink color, right? So there is sort of a story behind it, right? So this pink ribbon was made the symbol of breast cancer awareness program in 1992, right? So in this slide, you can see there was a lady called Evelyn Lauder, who was the CEO of a makeup company, a cosmetics company called Estee Lauder company. So in 1992, she started producing pink ribbons and products with pink ribbon in order to raise money to support cancer research and cancer support in the US, right? So she would produce products like, she would make these cosmetics, these lipsticks and perfumes and things, and part of what we pay for it will go to cancer research and support, right? So this is how. So since then, since 1992, pink ribbon has been made an integral symbol in breast cancer awareness, right? I don't know whether any of you were aware of this, but even me, I got to know when I went for my overseas training. Okay, so that is the significance of, that's the story of this pink ribbon, wherever you see it in the posters, right? A little bit of history. So the humankind, or we have been aware about breast cancer since 6,600 before Christ, where first breast cancer was, I mean, few cases of breast cancer was recorded in Egypt, right? And after that, there have been several attempts at surgery, but the successful surgery which was carried out for some time was by uh, doc, Dr. William Stewart Halsted, right? In 1882, there was a surgeon called Halsted who performed the first radical mastectomy, right? So this remained the standard for some time till 1970. So he started doing that, and after the World War II in 1995, 1945, chemotherapy, cytotoxic chemotherapy, was used in the treatment of breast cancer. Right after that, again 1950, radiation for breast cancer started. Right, slowly the treatment of breast cancer evolved, and then 1952, the first peer-to-peer support group was formed, and as I mentioned before, 1992, pink ribbon was adopted as the official symbol of National Breast Cancer Awareness Month. Right. Okay. So this is sort of how breast cancer management and awareness evolved over time. Okay. So this is for for your interest. So Halsted did mastectomy. So what he did was he removed the breast, the underlying muscles, pec major, pec minor, of the chest wall. So and the contents of axilla. It was quite radical, and after the surgery, the look was not quite pleasing. Right, only it was an ugly scar, and there was only skin over the ribs, and yeah, so not a very good result, but he may have achieved reasonable oncological outcome, but it was sort of over treatment. So we have come a long way. Anyone knows what this is? But this thing in the middle of the images. So it is a silicon implant, right? So don't think that it is used somewhere in Colombo or in one of the central places. We use it in Batiklo, right? Whenever we get a chance. And so this is we do a complete mastectomy, right? Skin sparing mastectomy, and put an implant inside. So I showed you that is we have come a long way in terms of treatment of breast cancer, right? See, from this radical Halsted mastectomy to this implant-based reconstruction, where the lady gets to retain a normal-looking breast, right? Okay. Right. So we have come a long way in terms of treatment of breast cancer, isn't it? From radical surgery, as I showed you, to conservation of the breast. But have we progressed in terms of finding early lesion and catching the disease early, especially in Sri Lanka? So still we see a significant number of patients with late presentation, right? So if you see this picture, so this lady, I think so 67 years old, she came to me to the breast clinic with this lesion, right? Do we think this is an early lesion? Even, I mean, you can't even identify the breast, isn't it? You can say it is the breast because the axilla is nearby, and whatever remains of the nipple is there, right? So this is a locally advanced breast cancer. She has been keeping this lesion for 1 year or more. Okay, so this is the kind of presentation we see, despite me doing implants and reconstructions. No point if patients come in this stage, isn't it? So there is something wrong. So again, this is also a sad story. So this is a 43-year-old lady, right? She's actually the sister of a doctor, and so she has been having this ulcer in her inframammary fold. As you know, inframammary fold, very difficult to see, isn't it? It's hidden. So she has felt that there was something, but she has not actually gone into the trouble of checking what it is. At least she could have told her sister. So she kept this. This was there for more than 6 months, and then she developed a supraclavicular lymph node, for which she showed to her sister. Then sister went back and saw this. So again, very late presentation. So whatever we do surgically, if patients coming like this, I mean, it's the outcome is not good. Again, another patient. This patient also, she came with supraclavicular lymph nodes, and when we went back and checked in the breast, there was a lesion in the breast, lump in the breast. Okay, so locally advanced, or sort of, this is a metastatic breast cancer. So this is the kind of patients we see, right, in our clinic setup. And yeah, this is another one. See, this patient's, axillary, it's actually a cancer in the axillary tail, right, which goes near the axilla, which it is also locally advanced. So if you see this image, you would easily understand that, the later the stage, the poorer the outcome. It's the obvious thing, isn't it? And see, when you, hold on a second. When you go to stage 4, the 5-year survival is only 16%. Yeah, I know. Right. Okay. So whatever we are doing is not enough, isn't it? Whatever we are doing is not enough. We have to do more and find out where it is getting, where we are making the mistake, or whether we are not doing enough, isn't it? So the WHO, World Health Organization, its Global Breast Cancer Initiative has planned to reduce global breast cancer mortality by 2.5% per year, right? And when they do this, they can avoid 2.5 million breast cancer deaths between 2020 and 2040. So they have planned to reduce breast cancer mortality by a huge number, right? So again, so how are they going to achieve this? So there are 3 pillars through which they plan to achieve this, right? One is health promotion for early detection, right? Health promotion. We are doing something, but it is not enough. Health promotion is the same as breast cancer awareness, isn't it? We are doing something, maybe we are only concentrating in the month of October and then forgetting about the whole thing, rest of the 11 months, isn't it? So 3 pillars WHO is planning is health promotion and yeah, hold on a second. Hold on. Yeah, sorry about that. What a call. Okay, so the 3 pillars are: one is health promotion for early detection, timely diagnosis. What do I mean by timely diagnosis? Now, say if a patient, finds a lump and comes to the clinic, comes to a surgical clinic, the patient should be diagnosed quickly. So where I was working in the UK, we have a thing called 2-week wait, right? From the time the patient develops breast cancer symptoms, the patient should meet the specialist within 2 weeks, and within the next 2 weeks, the patient should have the diagnosis, right? So that is timely diagnosis. Uh, in my breast clinic, I try as much as possible to get this done. Well, I personally go and see the mammograms, I speak to the pathologist, but that is not possible in the long run, because when the volume of patient increases, it's not possible, right? So we should have dedicated breast clinics, which are called one-stop breast clinics, right? Right, anyway. So third thing is comprehensive breast cancer management, right? Comprehensive. So that is happening in our oncology or oncosurgical unit, where patient comes, gets diagnosed, has the surgery, then after that chemotherapy, radiation under a single roof. Comprehensive breast cancer management. So all these 3 would help to reduce this mortality, right? And we will probably save a lot of lives by doing this. Okay, I'm unable to move to the next slide.
So you can try stop sharing the screen and then again starting.
Okay. Okay, right. Sorry. Okay. Okay. Right. Okay. Sorry for that. Sorry about that hiccup. We should be okay now, I suppose. Yeah. So, yeah. So, some facts about breast cancer, which we all know, it is the commonest cancer among females, isn't it? And in Sri Lanka, we diagnose around 3,000 new cases each year. Now, this is what the from the data collected, but it may be more than that because in Sri Lanka, we know how data collection happens. Isn't it? It may not be accurate. It may be probably more than 3,000 cases per year. So, you all, the students who have done appointment with me, must have seen this. Chart. So breast cancer is the commonest cancer among females in Sri Lanka, right? Right. In the UK, of course, 1 in 8 women will have a breast cancer. Sri Lanka is roughly around 1 in 12 women can get breast cancer. So this month, last month, okay, breast cancer awareness month is a chance for all of us, to take some time and acknowledge those men and women whose lives have been affected by breast cancer, right? So we remember them, right? So is it enough? Acknowledging is not enough, isn't it? So we should act. What are the ways what can we do? How do we act? So one way is we spread awareness. So when you go home, you can speak to your household, your family, your neighbors, your friends about breast cancer, okay? And spread the awareness, right? And so it's sad to see lack of awareness present even among medical students, right? Hopefully that would change soon. So the aim of spreading the awareness is to hope that the patients probably present early, right? To make them present early, and also one of our duty is to support these cancer patients, isn't it? Right. So in this month, at least during this month of October, we should do some awareness and at least support in some way, right? So this is one way. A leading charity in Sri Lanka is supporting breast cancer patients, right? So this is Indira Cancer Trust is actually this Karu Jayasuriya's daughter's charity, right? So they are doing a lot actually. So their motto is supporting the fighters, admiring the survivors, honoring the taken, and never give up hope. Okay. So this is one way people are trying to make the lives of these patients better, isn't it? So how do they do that? For example, they do this, they donate their hair to make wigs. Okay. So you know that wigs made of real hair look better than these artificial wigs. Okay. So these are done by these charities. Okay. Now, okay. So what can we do? So what are the tools we have? Right? What are the tools we can tell for early detection? One is, as you all know, self-breast examination, right, which can be done by anyone, but the people need to be taught, right, how to do it, isn't it? Right? At least when if they start giving attention to their own breast, there will be a lot of patients who will come with early presentation, isn't it? And clinical breast examination, either by by the doctor or by a trained nurse, and being breast aware, knowing one's breast and knowing what the changes which happen, and noting the instant that there is something new, when there is something new, when one knows about the their own breast, isn't it? And then, of course, screening, which is adopted widely in developed countries. We are striving hard to bring screening to Sri Lanka, right? It's in the pipeline. So who should start doing these things, right? Mainly this self-breast examination, all women, all females above 20 years of age, right? Especially females with family history of breast and ovarian cancers. Okay, so this is a small, there is an image showing, right? So one should stand in front of the mirror and inspect their breast, okay, look for changes, any dimpling, skin changes, okay, nipple retraction, asymmetry, fullness, right, ulcers and things. And after inspecting, one starts palpating, okay, either up and down, circles, right, or during the shower, okay. This is actually a brief way, but you all can see videos in YouTube, right, which is available for self breast examination. Okay. So what do we look for again? The signs and symptoms. Any lumps, nipple changes. Nipple can go in. Nipple can, there can be uh, discharge coming from it. Okay, and skin changes. It can have. I mean, in advanced cases, pody orange and skin dimpling, tethering, and change in shape. The upper pole, maybe there may be fullness, right? Change in shape of the breast. Again, nipple discharge, but the thing is, nipple discharge is fairly common. So mainly, we worry when there is bloody nipple discharge, mastalgia, breast pain, and of course, any changes in the axilla, lumps. Okay. So these are things you note during self-breast examination. And here it's a picture of a nipple discharge. So the discharge, when you have a patient with nipple discharge, you have to notice whether it's multi-duct or single duct. We are worried more when it is from a single duct and when it is bloody, right? So when you see a patient, so this patient needs triple assessment, and the smear is taken for cytology. Again, this is a patient with nipple retraction, isn't it? So probably there is a tumor underneath pulling the nipple, but not all retractions are cancer. So some people have congenitally also. Some people develop after breastfeeding, right? But should not be ignored. Again, you can see here there is in the upper pole you can see the nodularity, some dimpling, and even the lump is visible. Yeah, this is an interesting thing. Any weeping lesions, any lesions in the breast, right? Like like this looks like eczema, doesn't it? Right. So this is called, what is it called? It's called the Paget's disease of the breast. Okay. So this usually patients go to the dermatologist, and they get treated with steroids, and then come a few weeks or months later, which it does not heal. Then we do a punch biopsy, and it's diagnosed as Paget's disease of the breast. Okay. Right. So we spoke of ways of early detection. The tools for early detection is self breast examination, clinical breast examination, being breast aware, right, and screening. So what are the benefits of these tools of early detection? One is the chance of cure is more when a lesion is detected early, isn't it? And the outcome is better. And also when a patient presents with early lesion, chance of preserving the breast is more. And of course, less radical surgery, isn't it? Now I showed you two or three pictures in the beginning. All will have to have actually chemotherapy in the beginning, and after the chemotherapy probably will have to have a mastectomy. So because why? Because they presented late, isn't it? Huh? So now if a patient presents early, less radical surgery, and also can avoid, in certain cases, can avoid chemo and radiation, right? Well, that is what chemo is, what people fear after dying, isn't it? People, when patients are diagnosed with cancer, the fear is, one, first fear is dying, second is altered body image and this loss of hair and loss of the breast, and also the stigma. So these things can be avoided if the patient is patient presents early. And of course, yeah, one of the things is prevention of lymphedema, right? So 15% of patients who undergo axillary clearance will develop lymphedema. So if we do not do, if the patient presents early, we do not have to go for axillary clearance. We can do a sentinel node biopsy, and which will avoid clearance or lymphedema actually. So these are the benefits of early detection. Yeah, again, so stage by stage survival in breast cancer, right? So stage 0 is, pre-invasive, isn't it? Ductal carcinoma in situ and lobular carcinoma in situ. So survival is 100%. In stage 1 cancer is 90%, and when we go to stage 4, it is only 16%. Okay. So yeah, the outcome is better, obviously, when the patient presents early. So what? So this is a patient who has undergone a mastectomy, isn't it? So, but if the patient, certain patients, selected group of patients who present early, can keep their breast and only end up with a small scar in the breast. They don't have to lose their breast, right? Again, anyone knows what this is? What does this lady have in her left upper limb? It's obvious, isn't it? So she is having lymphedema of the upper limb, right? So this is post axillary clearance and radiation to the axilla. So as you all know, axillary clearance increases the risk of lymphedema, and on top of that, when we give radiation to the axilla, the risk is more. Okay. So when this lymphedema develops, it only keeps on increasing. It does not reduce. So I have done in Maharagam, I have amputated upper limbs because patients have come and told that it has become a useless limb. Okay, so it can go to that extent, right? So why? This is due to advanced stage presentation and radical surgery and radiation therapy. Okay, radiotherapy. So what we do routinely. So in particular, I do this. So this is called a sentinel node biopsy. So as you all know, there are about 20 to 30 nodes in the axilla. 70% of lymphatics from the breast drain to that area. So in breast cancer treatment, it is important to treat the breast and the axilla, right? So when patient presents early and when the lump is small, less than 5 centimeter, and clinically negative nodes in the axilla, we do a technique called sentinel node biopsy. That is, we inject a dye peritumorally or subareolally, a blue dye, and find the stained node in the axilla, and only take that out and surrounding 2 or 3 nodes and send for histology. Okay. So if that histology comes as negative, sentinel node negative for deposits, we don't have to go and clear the axilla. Okay. So sentinel node biopsy. So this avoids lymphedema and radical axillary surgery. So again, family picture. So patient getting chemotherapy. So chemotherapy also is not indicated for all the people with breast cancer, but certain types. And one of the indications for chemotherapy is late presentation, large tumor, lymph nodes in axilla, and of course metastasis. So patients fear this because loss of hair and host of other symptoms like severe vomiting and body aches and pains. So these things can be avoided if the patient is presenting late. Okay, I think that is enough. Yeah, I think that's about it. About the benefits, about the benefits of early presentation, and yeah, we learned something about this breast cancer awareness month. What the things which are done, right? We we take steps to uh, do to make people aware of breast cancer, and we try to support people with breast cancer, right? So now, so how can you reduce the risk of few ways we can reduce the risk of breast cancer? Even, I mean, there is a list here. Even when people practice all of this, only 30% risk is reduced. So there is a 70% other part we don't know, right? Which cause breast cancer. So prolonged breastfeeding is known to be protective, and regular physical activity, right? Weight control, avoidance of harmful use of alcohol, right? And avoiding tobacco smoke, right? Avoidance of use of hormones, and avoidance of excessive radiation exposure. So these steps can help reduce uh, breast cancer. Okay. Yeah, I think that's about it. Yeah. So, I mean, in summary, early detection saves lives, right? So, how can we make people present early is what I told you in the previous slides. Okay. So, it's a bit of a brief presentation, I suppose. Lalisha told at the beginning that it will be 1 hour, but actually, it'll get boring if I talk more than this. So I think if you all have any questions, I'll be more than happy to answer. So my aim was to to just if some people know that month of October, some students know that month of October is dedicated to breast cancer awareness. That is great. And if you all go home, when you go home for holiday, and if you talk to few people about self breast examination, clinical breast examination, the signs and symptoms of breast cancer, then that will be actually that will be the success of this presentation. Okay. All right. Lalisha, over to you.
Yes, sir. Thank you, sir. So before moving on to the question and answer session, let me first give a sort of an introduction. So this session was organized by this session particularly under the guidance of Dr. Ram Prasad and Dr. Vahidehi, who passed the message. So it was organized by the Explorer Society of the Faculty of Healthcare Sciences at the Exeter University. So this society was a pretty new society that was started very recently during the lockdown period. So it has since then we have been doing this sort of webinars and awareness programs with the current that were relevant to us in the field as well. So we will continue doing these kind of things, and I make this an opportunity to invite you over to join with us, and hopefully we will be able to do some interesting work with with the lifting of the restrictions, possibly some more things as well. So starting off with the question and answer session, I think we have got some questions. So starting off, well, sir, there's a question as in the breast. I mean, there are many other tissues that we can see the cancers being developed. So when it comes to the breast, what is the factor that makes it so much prone to for a cancer to develop, sir?
Yeah, that's a good question. Well, I mean, cancer can arise anywhere, isn't it? So, so the thing people, I mean, the breast undergoes, these cyclical changes during, uh, you know, during the, menstrual cycle. It undergoes cyclical changes. So it has, it's a dynamic organ, isn't it? The cell division and, the hormonal influence and a lot of things take place there, right? And say if you take the, lungs or rectum, they don't have this, cyclical variation. So uh, because of the cyclical variation, there is a lot of, molecular activity and hormonal influence, fluctuations um, uh, in, cells and things are going on. Maybe there is no, you can't pinpoint, but they say because of this, because of cyclical changes, it is more prone to cancer. But uh, yeah, there is no single answer to that as far as I know. um, so I don't know whether if I answered your question, but that is the thing they say because of this hormonal variation during,
Yes.
the and yeah, a lot of influences due to hormones. Um, yeah.
Yes, sir. Thank you for that answer. And we have another question, sir, asking about the treatment. What is the final margin for the surgical intervention? Is there any place for bilateral mastectomy? I think there are two different questions. So, what is the final margin for surgical intervention?
Yeah. So the margins have been debated for a long time, right? Initially, they said at least 2 centimeter margin for invasive cancer, and then it came to 1 centimeter, then came to 0.5 centimeter. So now the current conclusion or current consensus is negative margin is adequate, right? Say if we take, if we say we are doing a wide local excision of a breast cancer, and so the pathologist has to look at it, and if the margins are, negative, if when he cuts the margins and sees for cancer, if it is negative, that is adequate. So negative margin is the current consensus in terms of breast cancer. But invasive ductal carcinoma in situ is different. Ductal carcinoma in situ, the minimum margin should be, the minimum margin is 2 millimeter, right? So the larger the area of DCIS, the larger the margin. So minimum margin for in situ is more than the invasive. Invasive, negative margin is enough. In situ DCIS, 2 millimeter is the minimum margin, right? And yeah, that is about margins. Did you ask another question, Alicia?
Yes, so there's another question asking, is there any place for bilateral mastectomy?
Okay, yeah. I mean, uh, yeah, there is. I mean, in patients with S, so there are two factors, right? So some patients abroad in, other especially UK, say they have a cancer in one side, so they get scared and they ask for patient option, right? Patient prefers for the other breast to be removed, right? Prophylactic mastectomy, prophylactic contralateral mastectomy. That is one patient preference. We try to discourage as much as possible. Other thing is, this BRCA positive patients, because of, high risk of bilateral breast cancer, and also lobular cancer, which also has the has the propensity to develop in both breasts. So lobular cancer patient preference, and BRCA positive patients, they do go for bilateral mastectomy.
So we have another question asking, are both macro and micro calcifications associated with breast cancer?
All right, yeah. So these calcifications are seen in the mammogram, right? So when we do mammogram as part of triple assessment, in some patient, one would see two types of calcifications: micro and macro calcification. Macro calcifications are, more than 1 millimeter, 1 to 2 millimeters, and smaller than that are called micro calcifications. We are not actually not worried about macro calcifications. We worry when there is micro calcifications. And when patients have micro calcification, again we use a magnifying glass, or if it's in the console, we magnify and see whether it's a certain type, a pleomorphic microcalcification. If a patient has a pleomorphic microcalcification, it is more likely to be a malignancy or an in situ cancer, right? So when we find pleomorphic microcalcification in the mammogram, patient needs to be investigated further. Probably the patient needs a guided true cut biopsy from these calcifications to exclude ductal carcinoma in situ. So those are the difference between micro and macro. Macro, we are not worried.
Yes, thank you, sir. So we encourage you to ask any more questions. We can either switch on the microphones or send us the question. Sir, asking about the getting awareness and the support, I think when you consider worldwide, there are many movements. Even there is a test cricket match playing in Australia regarding the awareness of the cancer. So there are many movements. What is any ideas that you have, or any things that we are practicing here regarding the awareness, increasing the awareness for like what we think should be better, should be improved?
Yeah, we were doing this pre-COVID era. We were doing a lot. We were visiting schools and talking to teachers and students, giving talks, and trying to spread some awareness. And we went on walks on this month. Yeah, the thing is, I feel, yeah, two things should happen. One is, in whatever way possible, we spread the awareness and we try to form perhaps support groups, right? The thing is, the main factor which keeps patient from coming to the hospital is the social stigma, right? So if there are support groups, I mean, if we can form some groups, peer support groups with breast cancer patients, right? So say about 10 or 20 breast cancer patients, we get them together and have meetings, and so they can console each other or talk to each other, then that will take off the social stigma, and that will give some support, and maybe that may encourage patients to come and seek medical advice. So one is spreading awareness in the target or group, like school children, office workers, and another thing is trying to support, trying to form some support groups. So probably that, and I don't know how to take away the social stigma of breast cancer, because there is a patient now currently whom I operate on currently. She's away even from her family. Only she and husband knows that she has breast cancer. She doesn't want her children to know she has breast cancer. So she has rented out a house, and for this whole treatment, nearly 5 or 6 months, she has planned to live separately. So that is the social stigma, and the effect. Still, patients find it difficult to accept or discuss with others when they have breast cancer. So that, of course, I don't know. I mean, I don't know how to sort that out actually.
So thank you for the answer. So as a society, I think it's our responsibility as well to give them the social welcomeness that they deserve, and also not to discriminate them based on their medical conditions. So if there are any other questions, we can wait a few minutes. And if you have a, yes. Yes, you can ask.
Yeah. Well, Lalisha, more than the question, I just want to give a small a comment. And thank you very much, Ram, for that. I learned a lot from you, especially the pink ribbon campaign. I was not aware of it, so it was a lot to know. Yes, and I would like to make a point that medical students are always students, and I would like to recall the SARS-CoV-1 time when we were medical students, when we were asked, only you answered the question. Yes, about that SARS-CoV-1. I can still remember that. And I used to tell the students as well that,
thank you.
Yeah. So
thank you for remembering the good things, by the way.
Yeah. And yes, and such that now I realized how that poor microbiologist would have felt when we were like blank, and luckily you answered that question. So anyway, I hope students must have learned a lot through the presentation, and it was really happy to see the advancing therapies available in Batiklo. That message should reach the public, and I understand that COVID has put a big barrier to the activities that you all have been doing. But hope with this reduction in case numbers and all, you will be able to restart the things. And as the faculty, we will be with you. And I hope, Lalisha, the society also, they are very, very active students are in it, and they will also support. Yeah. Thank you. Thank you very much, Ram.
Thank you, Vedi. Thank you for the opportunity, actually.
Yes, well, thank you. Thank you for the comment. And let me make this a moment to remind that give the credits to our academic staff, and especially Dr. Rajiv and Dr. Jayaruban, who were advising us to start this kind of work. And also regarding questions you have, you can forward us. I have already put in the chat box any links that you can connect with us. We have our WhatsApp group, so if you are a member of the student of the faculty, you can join with us through that. And there's a Facebook page, and there are some videos that we have done regarding certain psychological experiments and certain other things that are interesting. So do join with us, so we can do some interesting work in the future, hopefully. So with that, let me make this opportunity to thank Dr. Ram Prasad for the great presentation and the knowledge that he shared with us today. So it was very insightful and useful for us as the students. So thank you for taking initiative to conduct this sort of an program, sir. We will look forward to have more these sort of discussions with you and many other members of our staff, with depending on the time that we have. And I think if there's no other questions, it is time for us to wrap up today's sessions, and hopefully we will be able to. Yes, hopefully we will be able to conduct another session soon enough. Until then, thank you very much, and have a good night. Yes, thank you.
Thank you, Lalisha. Thank you, students, for your patient listening. Thank you.
Thank you all.